Sarah, you need to unmute yourself.
Dr. Reese Ueno, Dr. Rita Bell Fernandez, our geriatrician, Dr. Lucas Morgan, who will be joining us shortly, along with Dr. Courtney Nunokawa, our nurse practitioner. As a little note with regards to sponsorship, we want to say thank you to our co-sponsors with Queens Medical Center and the University of Hawaii John A. Burns School of Medicine, Department of Geriatric Medicine. As a reminder, just a little housekeeping, evaluations are required should you decide to request CMEs, and you can find the evaluations by following the link in the chat or at any time on our website and email advertisement. We're currently offering continuing medical education for MDs, DOs, RNs, our nurse practitioners, and physician assistants. We also, for this session, are providing certificates of attendance for CNAs and students. And just to remind you, you will be sent out by Queens Medical Center by mid-January next year. You will receive the CME records. Your comments, your feedback on our geriatric is very helpful to the planning committee, and it really helps us get a good picture of future presentations that would be relevant to your interest and education. So about ECHO, we want to emphasize that this ECHO webinar serves as a forum for mutual teaching and learning from experts and from each of us that are here on the front lines. As the ECHO motto goes, all teach, all learn. And in the spirit of aloha, we encourage you to turn on your camera to help us build a community of living. If you also want to rename by your name the profession that you're with, that would also be helpful. Feel free to eat lunch because good nutrition is key to keeping a healthy lifestyle. Just a little bit more about the webinar format that will consist of a short lecture from our expert presenter today, followed by open comments from the expertise of our ECHO Hub team. And then you, the attendees, have the opportunity to ask questions, provide comments, and even case examples. If you do decide to provide us with any kinds of case examples, we ask that you keep the discussions HIPAA compliant. And this includes not sharing patient's name, birth date, address, and so on. We learn best from our patients and our clients, and they are our best teachers. So this afternoon, I'm so happy and very honored to be able to introduce our esteemed physician, Dr. John Awad. He's a physician for more than 10 years with the Senior Medical Science Liaison based in Walnut Creek. And he has lots of experience, more than 10 years in internal medicine and primary care. He excels in clinical trials and operational excellence in gastroenterology, nephrology, hepatology, kidney transplantation, and internal medicine. Wow, that's a lot. I don't know where you find time to travel to Hawaii, Dr. Awad, but this is a very relevant topic, I think, for a lot of us today, because he will be addressing considerations and factors for switching and augmenting medications for major depressive disorder. I just wanted to add Dr. Awad is skilled in fostering relationships with the key opinion leaders and delivering impactful presentations. He has held many roles with the Otsuka Pharmaceutical, Lundkrot Pharmaceuticals, Bayer Consumer Health. Of note, I think a really important career highlight to mention here is that he took the lead in the relaunch of Rexulti for agitation with Alzheimer's disease and the pre-launch of a medication called terlipressin. So we welcome you. A fond aloha, as we say, as we welcome you. And here's Dr. Awad.
Thank you very much, Sarah. That was a lot. I didn't know that I did so much. I really appreciate that. And it's my pleasure to be here today. And it's always a pleasure to foster education and foster significant relationships along the way. And just let you know, I do have a passion for research, and I really do have a passion for all the educational events like the ECHO meetings all over the nation, and even especially in Hawaii. I love to deal with the doctors and the clinicians, pharmacists, even like whoever I can find there to educate and to really help connect the medical network together. So it's a pleasure to be here today. Thank you, Sarah, for the introduction, and hi, everyone. Of course, I cannot introduce myself more than what's happened. My name is John, and it's my pleasure to be here today. I'm based in Northern California. I'm a senior MSL at Otsuka Pharmaceuticals, and I cover Northern California, Northern Nevada, and Hawaii. And just as Sarah mentioned, I do have a passion for internal medicine, primary care in general. And one very important topic as a primary care physician that we um, have mentioned previously is the challenge to treat major depressive disorder patients. Depressed patients are on the rise. It's not something that is going to go away soon. So it's always important for us to know the considerations and factors for switching and augmenting medications for major depressive disorder. Again, my presentation is paid for by Otsuka Pharmaceutical. That's a non-branded disease state only slide deck. It's not something that is going to discuss any promotional medication or any medication that's currently FDA approved or in the pipeline. I'm a paid employee by Otsuka Pharmaceuticals. That's the objectives. They are all present online for you also to review. So I'm not going to spend a long time here, but hopefully by the end of the next 20 minutes or 25 minutes, we will be able to know what are the factors to consider when we have a patient that's coming up in our clinic or even in our pharmacy, or even in the inpatient in ward, where they do not have full control of their depression symptoms or no control at all. What to consider, what to know, what does the evidence say? Each and every word here is totally research backup. So first, let's talk about the story here. And the story really comes and starts that in 2015, there was approximately 16.1 million adults that were 18 years and older that had at least one major depressive episode in the past year. So 16.1 million. And that's approximately 6.7% of the US adults. Saying that, when these patients follow up with their primary care physicians or their psychiatrists, there's always psychosocial disability, and there's always this leniency towards having a faster relapse compared with other patients who are on remission. So the real need here is to know, do these patients really have control of their symptoms, or there's something that is called residual symptoms? And let me define here, what are residual symptoms and what do they mean? We all know that there is multiple subjective complaints of depression, which includes like sleep disturbances, loss of interest, which is anhedonia, like guilt, like patients with appetite disturbances, patients who do feel sad most of the time, and anxiety, suicidal thoughts. We ask about these. But the patient is going to come with a set of symptoms, and maybe they have in the next visit, the next month or two, they come with, they say, I'm significantly improved, but I still can't sleep better. I'm significantly improved, but I cannot really eat as much as I can before, or I cannot even stop eating. Sometimes they'll come to you and say, you know what, I can sleep better. I feel okay. I don't have the sense of guilt, but I still can't really get out of bed to play with my kids. This is anhedonia. They don't want to go to the movie theaters with their wives or their families. They don't want to go to gatherings. That's loss of interest. And sometimes we just say, you know what, it's okay, continue on the treatment. But is that the right thing to do or not? That's what we're going to show today. And that's what it's called, a residual symptom. So there is recovery of symptoms, but there are residual symptoms remaining. And studies show that when you either increase the number of treatments, even if you sometimes even increase the number of doses for the patient, it's not always the case. It's not always helping them. That whether you put on a treatment or two, or whether you even add a dose, it doesn't really help a lot. As you can see here, that in a study in the United States patients for major depressive disorder, 8.6% switched antidepressants during the first days of therapy. And 2.4% added a second antidepressant as an adjunctive agent. And when we talk about these numbers here, put in context the millions of patients that are there. Also, in a survey of patients, approximately 600 patients with MDD with inadequate response to antidepressant treatment, 39% reported feeling frustrated. And these patients are the ones who are going to come to you and say, hey, doc, is that the best thing that you have for me? Is there anything better? And then you're going to find out that they're either not taking their medication on a regular basis. Adherence is something here to consider, because then they're not going to be adherent to the medication if they don't feel it. And also, they're going to question the ability of me as a provider, or you as well, in order to know, is that the best treatment plan for them? So individualization of treatment and shared decision-making is key here when we talk about MDD treatment. And there are two sets of guidelines. That's too wordy here off a slide. I'm not going to go through the whole thing here, but I'm going to go in more details. The American Psychiatry Association practice guidelines for major depressive treatment and the International Consensus Guideline they developed by a panel of psychiatric experts. They outlined a universal algorithm for major depressive disorder. Let's dig deep into these two guidelines to know what do they say about the recommendations for treating either residual symptoms or inadequate response for major depressive disorder. So the American Psychiatry Association, which is a very big organizational body here in the United States for psychiatrists, they do have an annual meeting, tens of thousands of attendees there. I've been there a couple of times. They always say that when you have a patient that's coming to you, either start with a medication trial or psychotherapy. Wait for a few weeks, initial weeks. If there is no or partial response, assess adherence. Are they taking the medication? Are they going to the psychotherapy? Never assume. Even, and as I always taught in my residency, even if they say, do you take your med? The answer is yes, I do. Well, how often? Is it every day? Is it as prescribed? And what do you take it with? And when do you take it? You've got to dig more into that. Yes or no is not really the answer that we're searching for, but you really want to know, are you taking it as prescribed or not? So it's very important. Even psychotherapy, do you attend? Yes. Do you attend the full session? How is it going? Are you happy with it? Dig more into the adherence here. And you wait for 4 to 8 weeks, which is 1 to 2 months. If there's still no or partial response, the American Psychiatry Association here recommends to always reappraise the treatment plan. So check again if that's the best thing for them or not, either by optimizing dose of current treatment, switching antidepressants, augmenting with a second agent, or even electroconvulsive therapy, which is ECT. And if the patient is on psychotherapy only at that time, then change the intensity or type of psychotherapy or combine it with a medication, as you can see here. And something I want to highlight here is the level of evidence is very important here, is that sometimes level 1 is always recommended with substantial clinical confidence. Level 2 is recommended for moderate clinical confidence. Level 3 is just maybe recommended on the basis of individual circumstances. So you really want to look at the level 1s and level 2s here when we're talking about the recommendations. And that's sort of a breakdown of what are the augmentation options. So they found out, and that's going to come in future slides, but I'm going to put it here first, that when you augment a treatment, so suppose that you have an antidepressant on board, if you augment this antidepressant, whether with psychotherapy, with another antidepressant therapy, with an antipsychotic, thyroid, or even mood stabilizer, you get better response. There's better efficacy rather than increasing the dose. And the augmentation options here, as you can see on the left side from a publication in 2010 by the APA, shows psychotherapy has level 1. So always combine psychotherapy with the first antidepressant. Then level 2 comes second antidepressant therapy, atypical antipsychotic treatment, thyroid hormone, mood stabilizer. Then level 3 comes anticonvulsants, psychostimulants, folic acid, omega-3 fatty acid, and anxiolytics. And honestly speaking, folic acid here, although it's level 3, but I have seen it a lot when it comes to treatments that are accompanying the antidepressants, especially in the rural areas. That's one of the modalities that is being used by multiple psychiatrists that I've talked with. What about the international consensus on optimizing antidepressant therapy? They have almost the same, but they look at things from a different perspective. So you see that the APA was a bit structured, the level of evidence and everything. Here, it's a bit different because here, when we talk about pharmacotherapy, they always say begin pharmacotherapy with an SSRI, SNRI, or even a noradrenaline dopamine reuptake inhibitor. And when you consider the initial phase, it's usually 2 to 4 weeks before assessing the symptomatic improvement. And after that, you've got 4 options. And it all depends according to 2 major factors. First is whether there's adequate improvement or not. And the second is there an acceptable tolerability or not? So based on these 2 factors, the improvement and the tolerability, you will see what you can do with this patient. So first is either to increase the dose of the medication. That happens if the dose does have an inadequate improvement. So they're not improving much, but they are tolerable. They can take the medication. They're happy with it. And the second is either you just keep the patient on the current dose if they're having the improvement and they're tolerating it. Third is decrease the dose in case they have some side effects, yet they feel better. But if they don't feel better and they do have poor tolerability with side effects, then you can switch the patient to a different agent. And the question is, what agent now should I use? And that's going to come in the coming few slides. So always assess based on these 2 factors. And saying that augmentation or combination strategies include, but are not limited to, mood stabilizers, atypical antipsychotics, steroid hormone, or even non-adrenaline dopamine reuptake inhibitor, as we have mentioned in the previous slide. So again, implementing the treatment change. When you have that in front of the patient and you're in the encounter with the patient, you're talking with the patient here in the room and they don't feel good about it, you've got to take really firm decisions. And again, the strategy for partial or non-response here is very individualized. Many patients are going to come in and everybody has their own story. And if you take one strategy with one patient, it's not going to be the same with the other. So, and here we really want to show the evidence part of it. So the MDD treatment response strategy here shows that research basically has been done on thousands of patients. And patients with depression often fail to respond to first-line treatment. The STAR*D trial, which is one of the biggest studies that is done in all psychiatry, it's very well known among all psychiatrists and residents. It shows that 2/3 of patients with MDD failed to experience remission following the initial treatment with a first-line antidepressant. So approximately 66%, 2/3. And in the same study, patients requiring 1 or more treatment steps, whether switching treatment strategies, resulted in adequate symptom relief in approximately 1 in 4. So if you switch, you get 1 in 4 patients success. But if you add an adjunctive therapy, you get success in 1 out of 3 patients. And that's what I'm saying. Adjunctive treatment addition had a better success rate than switching treatments when it comes to treatment of antidepressants. And there's even more to that. In the current research, sometimes like Dr. Roger McIntyre or the psychiatrists in the American Psychiatric Association, they can give really good treatment strategies about which ones really you should use when it comes to augmentation and adjunctive treatment. So recommendations from the literature here shows that, and that's based on a Journal Clinical of Psychiatry publication, prior to initiating a treatment, differentiate between the depressive relapse during antidepressant use and non-response. And here, just I want to remind the audience here of what is a relapse, what is non-response, and what's a remission. And it's always about the duration of the symptom improvement. So if the patient improved for less than 6 months since the initiation of treatment, and then he had onset of symptoms again, that's called a relapse. But if they stayed improved for more than 6 months, then that's considered a remission. And then if they don't have any improvement, that's called non-response. So if they don't improve at all, that's called non-response. Versus the relapse when they had improvement in less than 6 months. So first, you've got to obtain detailed history, rule out non-adherence. So you've got to really know if the patient is adherent to the treatment or not, establish adequacy of treatment, conduct a diagnostic reassessment. So always ask and ask and ask about the symptoms, confirm or change the diagnosis. And again, these are all recommendations. Individualization is extremely essential. Also, choose evidence-based treatment strategies, whether switching or augmenting or increasing the dose. You've got now in this slide deck here the levels of evidence, so it's all based upon your decision at this point. Also, consider the tolerability of first-line treatment and the possible loss of benefit of first-line agent when considering switching, combination, or augmenting. Ask the patient about the possible side effects. Sometimes stigma and culture plays a role here, especially when it comes to side effects like sexual dysfunction, which is a well-known side effect of SSRIs. Are all the patients going to talk about that? Especially when it comes to weight gain. Sometimes they don't even consider that as a side effect. Is that something that's possible? Yes, it is. Very common. So always keep these common side effects that the patients are not going to talk about in mind. You ask about them proactively, and you'll be surprised by the amount of yeses you get from the patients. So that's a clear evidence-based comparison about the advantages of switching antidepressants versus the advantages of augmentation. And this is just to help you here make a decision. Switching is going to give you a lower risk of drug interaction, so the patient is going to be on one antidepressant instead of two. Potentially better patient compliance, one tablet better than two, and also always consider polypharmacy in geriatric population, less costly, and also favorable for patients who experience intolerable side effects to the first line of treatment. What about augmentation here? Number one, you minimize the loss of any therapeutic benefit from the first line of agent. So you're continuing other agents stopped. Second is that you avoid withdrawal symptoms from the first line of treatment, and the target side effects of the first line therapy usually are not seen because you already know what's the safety profile and what's the tolerability of the first line of treatment. So put these in mind. Every strategy has its own pros and cons. There's nothing that's like one size fits all. It does not exist in psychiatry. And I think that maybe this can help you a bit weigh what factors you consider in switching or augmenting treatments to a patient. When it comes to considerations in forming an augmentation strategy, number one to look at is to avoid contraindications. We need to know what medications go with which, and to avoid these contraindications, target a cumbersome symptom. Suppose that I have a patient coming in with sleep disturbance, with an anxiety, with like fear of specific situation, or even with appetite abnormalities. I have to know, what am I targeting? If I'm an anxious patient, my target basically is going to be towards norepinephrine or even towards the serotonin. But if I have anhedonia, I'm going to look at dopamine more. I wanted something that works on the dopamine more, just to work on this neurocircuit here. So tailor your treatment based on the cumbersome symptom that the patient is coming with. And if the patient throws 10 complaints in front of you, always ask, okay, which is the one that you really want to work on? And then you'll get the answer of the most cumbersome symptom. Consider comorbidities, like minimize the number of medication prescribed as much as you can. These patients will have polypharmacy, and consider compliance, which means how many times a day, cost, side effects, and how is it? Is it oral when the patient does have dysphagia and swallowing disturbances, or is it like in any other form? As we can, I don't think there's a lot of injectables, antidepressants, but they're definitely going to come in the future, hopefully. Consider the weight of clinical evidence for the effectiveness of a given strategy, and we have talked about that. So I'm not going to go like through this whole text here, but what we wanted to say is that based on the evidence in the last decade, augmentation strategies are recommended in most guidelines for patients with partial or non-responders in the clinical practice. And they include either second-generation antipsychotic augmentation, switching to different antidepressant, or combination of different antidepressants. Suppose you're prescribed an SSRI, you can add to it an NDRI, just to make sure that you cover the neurocircuits needed. And that's for the third bullet point. And among second treatment steps, the augmentation strategy has proven to be useful in enhancing antidepressant side effect, increased remission rates, and minimizing side effects, such as sexual dysfunction, as we talked about. Among these augmentation strategies, there's a lot of noise now about atypical antipsychotics and second-generation antipsychotics because they have demonstrated efficacy in the MDD patients, and they do have good outcomes in the placebo-controlled randomized trials that they've done. Also, atypical antipsychotics are the most studied class of augmenting agents to SSRIs and SNRIs for depression. That's why always when we talk augmentation, even in any Congress, the number one thing that comes in mind is the second-generation antipsychotics or the atypical antipsychotics. And this slide here just shows you, based on your cumbersome symptom, if you want to really work on a specific neurotransmitter or a specific neurocircuit, which class would you use? And again, for the guardrail, I'm sorry that we cannot add any names here or any medication names to the slide, but we are more than happy to furnish that information after the presentation if needed. And again, enhancement of dopaminergic neurotransmission like 5-HT1A, 2A, 2C receptor antagonism. And just to let you know, the 5-HT1A is receptor agonism. So you really want to activate the 1A and you want to antagonize or deactivate the 2A and 2C. For serotonergic neurotransmission as well, there's 5-HT7, alpha-2, and serotonin transporter inhibition. For noradrenaline neurotransmission, you've got the alpha-2 receptor antagonist, not the alpha-1, alpha-2, whether B or C. 5-HT6 receptor antagonism or even norepinephrine transporter inhibition. And there's other classes, that do work on multiple neurocircuits, which includes the glutamate. And we all know that like some medications out there in the market now, they're getting new indications for major depressive that don't work on serotonin, dopamine, or norepinephrine, but they heavily work on the glutamate excitotoxicity. Also, hormonal modulation, when you prescribe thyroid hormone, or even like corticotropin-releasing factors or others, they do exist, or sleep alteration as well. So this slide here shows you the classes that you can go with when you want to target a specific neurocircuit. It's all online. If you just like even Google, you're going to find which medications work on which receptors. Now we're going to take some case review trials here and know exactly how real-world determination can help. So in a case review study conducted to determine why patients with depressive disorder and inadequate response to antidepressant treatment were prescribed adjunctive antipsychotic, and this was done on approximately 411 patients, and the doctors that were involved were psychiatrists or primary care physician. And the most common reasons the providers chose to prescribe adjunctive antipsychotics were either to achieve better efficacy, symptom control, they know the product, level of functioning of the patient increased, tolerability, and even if the patient does have previous MDD, have CGIS, or which is the clinical global impression of severity, scores that are improved in previous antipsychotic treatment, or if they have been really long time of current depressive episode and they need something to kick in quickly and kick in strongly, then only they consider the adjunctive antipsychotics. Well, now the question comes when they chose not to prescribe adjunctive antipsychotics. Number one, of course, the preference of the patient. You tell the patient, especially in geriatric population, there's a box warning for all antipsychotics with dementia-related psychosis, increased mortality in cardiovascular events. And you've got to discuss it with the patient. The patient says, I don't want it. I don't want to have this class of treatment. So it's a preference. Number two is tolerability or safety concern. You've got, of course, like multitudes of side effects that comes with it, include extrapyramidal symptoms, weight increase, blood glucose and blood cholesterol increase. So you will have these concerns shared by your patient. Sometimes you have to choose not to prescribe antipsychotic. Also, a preference to reserve antipsychotic for major depressive patients with specific symptoms, such as patients with psychotic symptoms, psychomotor agitation, impulsivity, irritability, hostility, and bursts of anger. And as you can see, the percentages here all work. So some of the depressed patients will come with psychotic symptoms, and that's in 66% of the practitioners will choose to really reserve antipsychotic for these patients only, rather than the regular patient that comes in with multitudes of symptoms. So this just helps you to know what other practitioners and research shows, how they think. And again, here, as you can see, that's a graph that shows the percentage of patients on the x-axis. The y-axis here shows what are the real reasons for prescribing adjunctive antipsychotic. And as you can see that mostly it's because of better efficacy, symptom control, specific drug features with targeting specific neurocircuits, whether it's dopamine, serotonin, noradrenaline, or even others. And like, as you can see, sometimes convenience is their tolerability profile, but it really comes to better efficacy and symptom control, drug features, and the physician's familiarity with the drug. And that's what really is all about. What's my habit in using antipsychotics or even other antidepressant classes? Also, in the same study, healthcare providers expressed a preference to reserve antipsychotic for patients with symptoms. We've discussed that previously, which includes psychotic symptoms, psychomotor agitation, and other hostility, irritability, impulsivity, bursts of anger, and suicidal thoughts at the end. But surprisingly, look at the suicidal thoughts here. It's the least among all. So, which is really something that we can see common in the community. So I'm done. I hope that I'm not out of time. But to summarize, I hope that in this like 20 or like maybe like 25 minutes that we have done discussing it, there are several consideration recommendations from the literature regarding making treatment changes. There are two guidelines, the American Psychiatry Association and the International Consensus. The American Psychiatry Association is always going to look at what's the level of evidence, which is level 1, psychotherapy. Always remember that. Level 2 comes all the other modalities of treatment, such as thyroid hormones, second-generation antipsychotics, and level 3, which is something that is individual expert. The other international consensus, remember, it looks at the tolerability versus the improvement. And you've got the 4 options, which is going to be here on the slide for you to review after the presentation. There are several factors that should be considered when choosing between augmentation and strategies, which is number 1, and switching, sorry, which is number 1, tolerability of the first-line treatment. Number 2, the potential loss of partial benefit from the first-line antidepressant, risk of withdrawal symptoms, risk of drug interactions, and compliance. You've got to think about these. Also, augmentation strategies do include avoiding contraindications between classes. Make sure of the monoamine oxidase inhibitors. There's a lot of contraindications here, especially with geriatric population, with polypharmacy, with CYP2D6 and CYP3A4 inhibitors. Make sure to have this in mind. Consider potential symptom relief and comorbidities. What's my most cumbersome symptom? We've had some ideas how to ask about that. And consider clinical evidence when you have these strategies in mind. Last but not least, there's a variety of determinants used by physicians when considering prescription of adjunctive antipsychotics for patients with major depressive. Atypical antipsychotics are the most studied class of augmenting agents to SSRIs and SNRIs for depression. And it just comes because there's a lot of randomized phase 3 placebo-controlled trials within this specific class. And there's actually 2 or 3 medications with atypical antipsychotic, even more than that are approved for major depressive disorder adjunctive therapy. Saying that, I'd really like to thank you so much. And we at the PsyQ community would like to hear your feedback. So please reach out to us and download the application for PsyQ. Again, this is one presentation out of hundreds of slide decks out there in this community, and it's my pleasure to be here today. Thank you very much. We're now open for any questions, and I'm going to stop sharing now for the sake of questions. Thank you.
Thanks so much, Dr. Awad. This is Lucas Morgan here. I'm a psychologist, part of the team here, and yeah, thanks for a really informative presentation on a very challenging topic, which is medically and medication-wise, what happens when the first round of medication is not meeting the results that folks would want, and especially in geriatric populations that we work with, really complex questions, a lot of consideration. So I wanted to open it up to our panel first and check in one by one. Sarah, sort of from a social work perspective, your thoughts on this topic or anything in particular?
I'm just going to segue into what you were saying and piggyback about geriatrics. And I do have a couple of questions for Dr. Awad. I like the fact that you mentioned a little bit about being prudent on those antipsychotics. And I'm thinking specifically of the geriatric population that have some type of dementia. And so oftentimes, most family members don't realize that you can actually have depression while you're living with dementia, right? And oftentimes what they tend to see is more the agitation and the irritability. And at some point, I guess what I grapple with as a social worker for the family is to try to help them understand that it is a part of the depression and that they need to be an advocate and communicate with the primary care physician or the geriatrician. And so I don't know if you could speak a little bit about, because most families are panicking. They can't deal with it's the behavior challenge. They can't deal with that. And so they're charging into the doctor's office saying, I need, poor geriatricians and PCP, I need you to take control and knock them out.
You know,
With all these
this is exactly what happens out there, Sarah. And I can tell you that. So I've been in nursing homes myself, and we've seen patients, and I have stories to tell about patients who stayed 40 days in the hospital because of agitation that comes with dementia. So, but here you raised a very important point, yet it's also very challenging. How can I differentiate between agitation that comes as a part of dementia and irritability that comes as a part of depression? And always you have to know that depression is not something that is like switch on, switch off. It's coming and going. It's a very, very like vulnerable population that you're dealing with here. 65 plus patients, polypharmacy. What's their quality of life? Sometimes it's depression just comes with it, you know. If I put myself in their shoes, what is my life going to be, and what am I doing here? So that's always something that's going to be there. The question of, are they depressed or not? And here comes to really the caregiver input, especially if they're demented. The caregivers are the ones who are going to tell you what's the baseline of the patient. Is that my dad all the time? Did they change or not? So you have to ask about, number one, what's the baseline of the patient? Are they cursing now more than before? Are they yelling more than before? And what's the course of their dementia? And I can tell you that agitation, we think, and let me ask you just here out of curiosity, what do you think? Agitation comes in more severe patients with dementia or at any stage of dementia? What do you think? Usually, when do you see agitation?
Yeah, usually you'll see it. Well, I see it actually in the beginning stages too, because there's that frustration for that person when they have a moment of lucidity and they know they're losing their mind, and that makes them depressed. And it's like, and the next thing you know, because they're tired of, like, why doesn't anybody understand what I'm saying? You know, they think I'm crazy.
Exactly.
But they really can't remember asking about how they've asked their family member 5 or plus times, have I taken my medication? When are we going to eat dinner? What do we have? And it just goes on. So I think I don't know. What do other people think in the audience about agitation?
Let me first agree with you. 56% of the patients with mild cognitive impairment will have agitation. So you're right on that. Spot on. Okay. And I'm saying that because sometimes we reserve the agitation symptoms for patients who are really late or severe in the disease. The answer is no, evidence does not show that. It shows that it comes earlier. So how do I differentiate between both? Number one is evidence shows that agitation especially with Alzheimer's disease, they do have specific criteria. We can talk about this criteria in another slide presentation, which is called the International Psychogeriatric Association. There's 29 items, and there are scores that comes with this, okay? And there is also the MPI-Q, which will tackle the agitation part. So you've got to go with your metrics here. Where is my patient with the PHQ-9? Where is my patient with the MPI? And where do I really get the scoring? And that is where you're going to know whether this patient is agitation because of dementia or it's because of depression. Based on that, you'll tailor your medication. Now, your question about antipsychotics in dementia patients, this is a critical thing. All antipsychotics, again, especially atypical antipsychotics and typical ones, they do have a boxed warning for increasing cardiovascular mortality in dementia-related psychosis in patients who are elderly. So make sure that you uncover this with the patient and the patient's family prior to using any antipsychotic in this population, especially if they have cardiovascular mortality. There's some modifications to some antipsychotics based on indications. It has happened, but you have also to take care and take note of this comorbidity when it comes to prescribing antipsychotic in geriatric population.
Well, thank you for
Yeah.
very thorough response.
Yeah, appreciate that. And yeah, I think the question of depression within dementia is something that we're all dealing with in our own fields, and always a really important one. And yeah, how medications fit in the midst of that. Yeah, complex. Rita Bell from Geriatrics, what are some thoughts you're having?
I first would like to thank Dr. Awad for stepping in on very short notice to do this. Clarence Liu, who had an emergency, is unable to be with us. I know many were expecting a spiritual talk, but we'll have Chaplain back another time. So thank you, Dr. Awad, for helping us out. And your presentation took me straight home to my medical school in India. I really thank you for driving home these very key points, like taking a good history. And there are times that I have messed up by not asking or spending enough time on adherence, on that compliance. So I thank you for such an excellent presentation.
Well, thank you, Dr. Fernandez. I appreciate that. And I appreciate the opportunity to be here.
And Courtney, any thoughts from you in the nursing world?
Thank you so much for your presentation. I think I agree with Dr. Fernandez. The thing that is coming up is adherence, it becomes really frustrating for both the clinician and the patient. And when I worked in residential, I was an embedded primary care provider embedded in a mental health residential unit in the VA. So it's a subacute, not subacute kind of treatment setting. It was common for people to come in and have 3 to 4 treatment failures, antidepressant treatment failures. But when you actually do the adherence history, they never actually had the full trial of taking it daily for 6 weeks. And then oftentimes trying to restart them. But then there's this mistrust already in the medications in the system because they feel like they failed. So yeah, it goes back to the history taking and really ensuring that the adherence is what's actually happening. Another thought that's coming up is there's with adherence and also with antipsychotics is there's still a lot of stigma around medications. And I think that's where adherence it's more complex. There's belief systems. They tell a friend that they're on this new medication. Their friend has all these opinions and then they stop the medication or which I think is where support systems and psychotherapy can be an outlet potentially for people to kind of talk through some of those things and help them stay on the medication. But also coming from the VA DoD setting, antipsychotics are for a service member is essentially like service ending, right? Like once they're put on that medication, they're considered no longer fit for duty. And so there's a lot of belief, there's just a lot of occupational and different factors that are coming into the prescribed that is impacting getting people on optimal kind of treatment regimen. So yeah, really, really challenging. I appreciate the evidence-based kind of literature perspective. Thank you.
Thanks, Courtney. And Reese, how about from your experience in pharmacy?
Yeah, so at the pharmacy, it's not uncommon for us to see patients switching from one antidepressant to another. So when they do start a new antidepressant, we do counsel the patient and say, this medication does take time to come into effect. It's not going to be you take a pill today and tomorrow you'll feel much better, right? It's going to be maybe 1 month or maybe even 8 weeks it may take for effects to start kicking in. And I do think setting expectations to the patient does help with adherence. And another thing that was brought up in the slide deck that I thought was really important is keeping it individualized, treating the patient, other comorbidities. For example, we have some patients who are depressed and then they're having a hard time going to sleep or eating. So mirtazapine seem to work well in those patients, or a patient who's gaining weight or may want to even lose weight. Bupropion seems to be fairly effective, or maybe the best choice in patients dealing with those weight issues. And then also, occasionally I do see patients when switching with medications, more of a question, like a SSRI, is it better to switch to another SSRI, or maybe go to SNRI and just try something totally different? You might have mentioned it in the slide deck, but just want to double check on that.
Oh, so that Dr. Fernandez, do you want to take the question, or should I just answer it? I don't know if I have a really clear answer for that. There's no clear evidence on that specific matter. So there's no research that is done on whether to switch SSRIs with SSRI or SSRI with SNRI or even NDRI. So it really depends according to which agent. And to be honest with you, there's no set stone, but expert opinions out there, if you switch the class, usually you get better efficacy. That's what it is, because you're targeting different neural circuits. That's expert opinions. Again, it's not evidence-based, to be clear about that. So Dr. Fernandez, please let me know if there's anything.
Well, thank you, everyone, for, speaking from your perspective and experience. And yeah, definitely, I have a lot of thoughts about this area of discussion, being a psychologist, right? Because I have the luxury clinically of having more time to spend with folks than maybe other folks do, due to the nature of how medical reimbursements and stuff is set up. So, I talk to a lot of folks. Most of the folks that I work with are or have been on some sort of psychotropic medicine, especially that different antidepressants. And I don't know, I'm just trying to think about one or two things to say instead of like 12. But I like to always try to keep in mind that we're never gonna really fix anybody with medicines alone as far as their mental health, because thinking about human beings from a biopsychosocial, cultural, historical perspective, their chemistry, their biochemistry is one piece of them, but their needs as a human being are vast, relationship-wise, sense of purpose, their physical health and exercise and well-being and nutrition. And so, we should hopefully no one's falling into the belief that, there will be a medicine that fixes depression for everybody, because that's just too simplified a way to think about human beings. And that I like to talk, if folks are working with me and they're like, oh, my doctor's recommending a antidepressant, what do you think? And I'm like, well, let's think about what kind of tool this could be for you. And I like to talk about antidepressants as like, okay, if your mood is getting in the way of you making changes in your life, or getting some more of your needs met, the medication may be able to bring you up a few notches so that you can start to do the things in life that are the real medicine, making, more, healthy relationships, engaging more in things that matter to you based on your values. The medicine itself is not going to make those relationships for you, but it might help you get up enough so that you can start to do the work of behavior and life and context change that actually are the medicines for depression. And just to keep in mind that folks in environments like a lot of older adults find themselves, making those changes is not easy. So we want to always, I want to always have compassion for the fact that medicine might help feel a little bit better, but how can we help folks feel more connected, feel more have more purpose and meaning in their lives, no matter what kind of challenges they face. And, you know, I'd like to share as you know, to combat stigma, you know, I've taken Lexapro myself for almost 15 years. That's escitalopram. And there have been times when I was actually, you know, wondering about augmentation or substitution for myself, and just how hard of a process that was to think of all of, how do I know what to do? How do I know what's going to work? Do I know if this is working when I did try something new? And just, you know, it helps to have compassion being on both sides of it, to really remember that, you know, these are complex human beings on the other side of the chair, I guess you could say. So, yeah, I appreciate Dr. Awad, you know, coming in on such short notice and helping us think about this from our various viewpoints. Now, having taken up so much time myself, are there any folks here joining us that would like to ask questions or share some perspectives on this topic?
You know, where do you find neuropsychiatrists in Hawaii? Or, you know, it's just so hard. I mean, I thank you for, you know, having the courage to share with us your own personal experience, but that does kind of pop up in my mind, is trying to find a psychiatrist for people, for older adults that have multiple and complex social problems and physical. And I think it gets back to what you're saying, is the whole person. A lot of clients that I've worked with in the past, functionality is so important. They want to be able to get out of bed and pick up that grandchild and love on them, and, you know, play ukulele. They want to be able to get out to that luau and enjoy their favorite poi and whatever. But they, you know, they have the loss of interest. But I don't know. Does anybody have any answers, suggestions?
I think the interdisciplinary nature of care matters so much. And, you know, and I think each of us in our own organizations maybe have opportunities to encourage system change in little ways sometimes, to encourage, hey, why don't we think about adding this type of person to our team, you know, or why do we encourage increasing, you know, because geriatric psychiatry, I'd love to hear if other folks do have more ideas about accessing geriatric psychiatry. But folks in that field are, you know, a lot of geriatric folks are inherently bigger thinking, because we realize that no one field has all the answers. So
but I think we have to do something about that stigma, because most people, I hear them say, oh, that's a part of aging. People are always depressed when they get older. Wouldn't you be, if you can't go, you know, if you can't go lifting weights anymore or doing a marathon? And I go, no, that's not the case. It's not, that's not normal aging. But I can't seem to, I don't know, even my own peers. I'm kapuna now, more Lucas. I'm kapuna, and they, you know, like, I have to prove to them that as a kapuna, I still can learn. I may learn slower. I may move slower, but it doesn't mean that, and I do, sometimes I do feel down, but I know what I need to do to take care of myself, you know, and to make sure that I have those connections with people. But I'd be curious to hear what other people think about that stigma and how we need to work together to make change in society.
I can chip in here with a couple of experiences that we've had in Northern California region and Northern Nevada as well, as the advocacy groups and the cultural changes that comes with the events that they do, and how can we as a community get ourselves embedded with these advocacy groups and spread our culture and spread the culture that is appropriate for the specific age, especially when it comes to stigma. There are many events that are happening now about stigmatizing mental health, decriminalizing mental health, also like destigmatizing aging itself. And that is something that is appropriate, and it has been done. So focusing on advocacy groups, finding these groups and joining them in their events that they do you'll find a lot of patients there, and it has happened before that we made a difference.
Well, appreciate folks joining us today, and we still have a few more minutes for questions and comments. Just wanted to point out that there is John put up the evaluation link in the chat for folks to access their continuing education credits. So make sure to do that.
I'm just going to put a plug in here that there is the Out of the Darkness walk on September 14th. I'm not sure if you heard of that, Lucas. And again, the focus is on suicide prevention, you know, and
is that
yeah,
itself,
we don't want to get to that.
Is that a nonprofit itself?
Yeah, I don't know. I guess if you go to NAMI, they probably would
NAMI,
have it listed,
okay.
but it's a local, I guess it's Out of the Darkness. Just Google Out of the Darkness, and they'll be marching just around. I think it's the state capitol from Bishop Street to around the state capitol, just to increase awareness about, you know, suicide and depression and suicide.
Yeah, cool. Yeah, raising awareness, I think, is so critical, and all the different groups trying to do that. Anyone, have any specific thoughts on addressing, cultural stigma against taking medicines for mental health, and I use culture broadly, and there's sometimes, I don't know if people ever hear patients say, like, that seems like a weakness, or it seems like, taking medicine is kind of like a sign of weakness. Anyone ever encounter that, or have any ways that they kind of try to normalize or work around that kind of belief system?
Something that I say often is the brain is an organ, in the same way that we support the heart and the lungs and the liver with different types of medications. The brain also needs support. First, so instead of using the term mental health, it's something for your brain health as an organ. Yeah, works sometimes where it doesn't work others.
Yeah. Very cool. Yeah, humans are so individualized that, one thing might work really well and speak to somebody or work for somebody and not for someone else. But being human is not easy. So it's a lot of validation can go a long way in helping someone be open to trying something like an SSRI or SNRI.
I do think it's the younger generation. There's much more awareness, and in good and bad way. People are diagnosing themselves on TikTok and whatnot. So there's some challenges, but I think the work that generations have done have really changed the landscape for future generations. Is my hope.
Definitely. Well, thanks again, everyone, for joining. And we appreciate your time, Dr. Awad, and for, again, jumping in at such short notice, and really appreciate that. So, everyone have a great rest of your week, and hope to see you folks here next time.
Mahalo, Dr. Awad.
Mahalo. Bye-bye, guys.